I'm Dr. Jamie Koprivnikar. I am a hematologist oncologist at the John Theurer Cancer Center at Hackensack University Medical Center. I've been there for about the past 10 years, and my practice at the JTCC is really focused on the treatment of patients with bone marrow failure disorders, leukemias, myelodysplastic syndrome. I have a particular interest in the ultra-rare disorder of PNH, or paroxysmal nocturnal hemoglobinuria, and that really stems from my days as a fellow training at Georgetown University Medical Center, where one of my mentors actually became very interested in this disease after she encountered a patient with a diagnosis of PNH that was missed, and this patient ultimately, unfortunately, had a bad outcome. So after that experience in my training, I really kind of also became interested in PNH. And with the way that the field has evolved over the past several years, it's really just become so interesting. We now have a variety of treatment options for this disease, which once really did not have any satisfactory treatment options and was really a significantly life-threatening diagnosis. PNH is an acquired disorder of the hematopoietic stem cell. So it affects white blood cells, red blood cells, and platelets. And basically, PNH results from a mutation in something called the PIG-A gene. This gene codes for an important anchoring protein, the glycophosphodinoacetyl, or GPI anchor. And so this anchoring protein really attaches some important complement inhibitory proteins to the surface of the hematopoietic cells. So I like to think of these proteins known as CD55 and CD59 as being complement sort of stop signs. They basically help the complement part of our immune system to recognize our hematopoietic cells as being part of oneself, and basically prevents complement from kind of attacking our own hematopoietic cells. So again, in patients with PNH, they lose the mechanism by which they attach these complement regulators or complement stop signs to the surface of their hematopoietic cells. And so patients with PNH experience not only chronic intravascular hemolysis or breakdown of the red blood cells, but also chronic overactivation of the complement system, which really leads these patients with untreated PNH to be living in this kind of constant pro-inflammatory state that we really think sort of contributes to the fatigue and the thrombosis risk that's experienced by these patients. There is sort of literature that does show that PNH patients see an average of 5 physicians before arriving at a diagnosis. So it is typical of other rare diseases. The diagnosis is often delayed and difficult. In terms of the groups of patients that we want to think about PNH in, kind of first and foremost, we want to think about patients who have bone marrow failure. And so most classically, patients with aplastic anemia, but patients with other bone marrow failure disorders such as myelodysplastic syndrome, and also patients with unexplained cytopenias are patients who we should consider a diagnosis of PNH in. Other groups of patients who are sort of at risk of having this diagnosis include patients with thromboses, although there are lots of patients who have thrombotic events, but we really want to think about, PNH in patients who have blood clots in either the abdominal vasculature, the Budd-Chiari syndrome is kind of a classic presentation of PNH, or patients who have blood clots in the cerebral vasculature, things like strokes or, sinus vein thromboses. But I do want to point out that, patients with PNH often have blood clots in the deep veins and the pulmonary arteries. So certainly blood clots in any of these signature or hallmark locations, including the abdominal and central nervous system vasculature, but also any blood clot that maybe is resistant to anticoagulation or is associated with evidence of hemolysis or low blood counts. And then finally, patients who are hemolyzing. PNH at diagnosis is classically what we call a Coombs negative hemolytic anemia, but certainly for patients who have evidence of hemolysis through, hemoglobinuria or certainly through other laboratory markers should be tested for PNH. I will add that, really these patients with PNH can present with a very wide array of signs and symptoms. This is a disease, even though it is really a disease, that of the blood and bone marrow, it can really affect almost any organ system in the body. And so I think this is one thing that really leads to difficulty in diagnosing this disease. Patients may complain of abdominal pain, chest pain, difficulty swallowing, fatigue, erectile dysfunction. So you can see that it's really a lot of very kind of divergent and almost non-specific symptoms with which PNH may present. Sure. So the current standard of care for patients, with a substantial PNH clone that is resulting in hemolysis and sort of end organ effects or symptoms is really to place these patients on treatment with a complement inhibitor. So we can inhibit complement in a couple of different locations. The original complement inhibitors targeted C5 or terminal complement. We now have agents available that actually target complement more proximally, and there has been shown that for individuals who are experiencing persistent anemia on a C5 inhibitor, some of these more proximal complement inhibitors have been shown to improve hemoglobin levels. And so there are several of these proximal complement inhibitors that are available. And so when I'm, talking to a patient about starting therapy for PNH, it always ends up, I think, being a very highly individualized treatment discussion with hopefully a lot of dialogue between myself and the patient and, kind of explaining the options to the patient. But ultimately, treatment choices tend to be, I think, very patient-led in this particular disease. We really don't have, the studies that compare a lot of these agents in a head-to-head fashion. We do know that, the clinical trials have really shown that all of these agents can really be quite effective in the treatment of patients with PNH. So Fabhalta is one of our newer agents for the treatment of PNH, and it's really quite revolutionary in that it's our first oral monotherapy for the treatment of PNH. It is one of these agents that does inhibit complement more proximally. And so in doing so, it has been shown to really allow for robust recovery of a patient's hemoglobin. We've also, as part of the clinical trial program, seen very low rates of breakthrough hemolysis, which is always a concern. And so, for Fabhalta, it's really given patients the freedom to be able to kind of take the management of their PNH into their own hands and treat it, with a pill chronically, like we might treat hypertension, for example. So this is, I think really a significant breakthrough for patients and also for physicians like myself who are treating PNH. There's a lot to be said about PNH. I think, the most important thing is to kind of think about the disease. It is, an ultra rare disease, but if you don't kind of think about PNH, you'll never see a case, is how the saying sort of goes. And these patients definitely are out there. And, again, just kind of reiterating these three kind of high-risk categories of patients, or those with bone marrow failure, those with Coombs negative hemolytic anemia, and patients also with thrombosis. And, we're very lucky. This is the type of disorder that if we discover it and and are able to kind of find patients with PNH, we really have a variety of effective and convenient treatments. So I think that if you do kind of help to diagnose one of these patients, you can truly, change the course of their life.